Part 2 of the American Board of Physical Medicine and Rehabilitation's initial certification is an oral examination. The Part 2 examination is an interactive process between you, the candidate, and the examiner. To aid you in preparing for the Part 2 examination, the ABPMR has developed 2 videos showing the administration of sample vignettes. These videos give a flavor of the setting and style of the examination. We recommend that you watch Video 1 prior to watching this video. Video 1 explains the components of the Part 2 examination. This video will provide additional important information as well as another sample vignette administration. When preparing for the examination, please refer to the Part 2 examination information that is posted on the ABPMR website, including the information for candidates, the Part 2 examination outline, the examination irregularity, non-disclosure, and cooperation agreement, and the appeal policy. You will receive a Part 2 procedure notice by email which will include your admission card. You are required to bring this card to the examination site for registration. Professional business attire is strongly recommended. On the day of the exam, please plan to arrive 45 minutes prior to your scheduled start time. Late arrival may result in the loss of your examination seat. An orientation will be presented prior to the start of your examination. Each examination room will have the supplies you will need to complete the examination. Do not bring any personal items to the examination site. Prohibited items include, but are not limited to, any electronic devices, cell phones, pagers, recorders, computers of any kind, food, luggage, purses, notepaper, pens or pencils, books, or study materials. At the examination site, you will be asked to sign the examination irregularity, non-disclosure, and cooperation agreement policy. Signing this agreement prohibits you from discussing any aspect of the Part 2 examination with anyone at any time during the exam weekend or in the future. The ABPMR reserves the right to take whatever measures are necessary to protect the integrity of its examinations. You will also be asked to sign the Part 2 examination appeal policy. The following is a sample vignette. The types of questions posed by the examiner will vary with each vignette. This example is not meant to be all-inclusive of the types of questions encountered in an actual Part 2 examination.
Doctor, we need to move on to our next case. Please read yourself as I read it aloud. A 44-year-old secretary presents with right shoulder and upper arm pain for the past month. She has been limited in her ability to play tennis, which she does 3 times a week. She has been taking intermittent ibuprofen without relief. What additional history would you like?
I'd like to know the characteristics of the pain, what makes it better, what makes it worse, how severe it is.
The pain is constant and aching with a severity of 6 out of 10. The pain is worse with upper extremity activity, including secretarial work, and nothing seems to make it better.
Is there any history of a prior shoulder or neck injury?
There is no prior history of injury to the shoulder or neck.
Is there any weakness or numbness in the arm?
There is numbness and tingling over the lateral arm, and the patient complains of shoulder weakness.
Is there any difficulty with using the arm?
She notes difficulty while serving while playing tennis. Is there anything else that you'd like to know?
Is there any significant past medical or surgical history?
No.
Is there any significant family or social history?
There's nothing relevant in the family history, and social history is not available. Let's move on. What would you look for on physical examination? Remember, as we discussed at the beginning of the exam, a proctor may enter the room during the examination. She is here to evaluate me and the testing process. She is not here to evaluate your performance. So, just ignore her and let's proceed. Again, what would you look for on physical examination?
I would like to examine the shoulder.
And what specifically would your examination of the shoulder include?
Range of motion, evidence of shoulder instability, any positive impingement signs such as Hawken or near.
The patient has full passive range of motion, but active range of motion is slightly limited at end range by pain. There's no evidence of shoulder instability, and all impingement signs are negative.
Is there any evidence of muscle atrophy at the shoulder?
No.
Is there any tenderness with palpation of the shoulder?
No.
Is there any weakness or sensory loss in the arm?
Strength is normal, except for 4 out of 5 strength of the deltoid, supraspinatus, and biceps. There is decreased sensation to light touch over the deltoid.
Okay, with that weakness and sensory loss, I really should look at the neck. Is there any limitation to range of motion of the neck?
No.
I would do a spurling for nerve root impingement.
Spurling is positive.
Are there any deep tendon reflex changes?
Reflexes are normal. So, the patient has aching 6 out of 10 pain and mild weakness in the right deltoid, supraspinatus, and biceps. What is your differential diagnosis?
Well, given the information presented, I think this is likely a C5 radiculopathy.
What else would you include in your differential diagnosis?
Okay, I would consider brachial plexopathy, injury to the rotator cuff or impingement syndrome, adhesive capsulitis,
Myofascial pain in addition to the cervical radiculopathy.
What diagnostic testing would help you to confirm the diagnosis, and why?
I would consider doing plain film x-rays of the neck and shoulder. However, yield from these would be low. It could reveal bony abnormalities which could contribute to impingement or degenerative changes at the neck. Electrodiagnostic studies would be helpful in localizing specific nerve injuries at the neck or brachial plexus. One could consider doing an MRI of the neck or shoulder depending on the results of the initial x-rays and electrodiagnostic studies.
Assume the patient has a right C5 radiculopathy from foraminal stenosis. What treatment would you recommend for the patient at this time?
Well, I would start by helping to control the patient's pain with therapeutic dosing of a non-steroidal anti-inflammatory medication, or could consider a steroid dose pack depending on the severity of the pain. Other medication considerations would be gabapentin for nerve pain, amitriptyline if the pain is interfering with her sleep, a short course of muscle relaxant. If pain persists, I would consider a trial of opiates. I would advise the patient to try local heat or cold depending on what works best. I would recommend proper support for her neck at night and while working, as well as relative rest and avoidance of exacerbating activities.
Is there any other treatment that you would recommend, and why?
Well, for initial treatment, that's probably all I would do. However, I could consider initiating a formal outpatient physical therapy program using additional modalities and therapeutic exercise.
Let's move on. Under what circumstances would you refer the patient to a spine surgeon?
I would consider referral if the patient has progression of weakness or persistent pain that fails to respond to therapy. If she develops long tract signs such as
Increased lower extremity tone or ankle clonus.
that would certainly be an indication for referral. If the patient develops bladder or bowel incontinence, that would be an indication for urgent referral.
After 6 weeks of therapy, the patient's pain is well controlled and her strength is normal. She has been discharged from therapy with a home exercise program. She returns now to see you to request additional outpatient physical therapy. Assume I am the patient. How would you respond to my request?
You've made excellent progress in your therapy. Your pain is resolved, your strength is normal. Why do you think you need additional outpatient therapy?
I have difficulty motivating myself to do my home exercises, and I'm concerned that I'll get worse again.
I understand what you're saying. You're really describing two separate concerns. Lack of motivation to perform your home exercises and fear of recurrence of your symptoms. You've had good resolution of the symptoms, and it's unlikely that there will be a recurrence. Performing your home exercises will limit the risk of any recurrence.
Doc, you're not listening to me. I know that I won't exercise on my own.
That is a common concern. However, there are some good strategies that we could employ to...
Time is called.
That will conclude our exam. Thank you. Please proceed to your next examination.
We hope that you have found this video demonstration of an oral examination to be helpful. During the examination, you will cover vignettes with varied content given by 3 different examiners. Each vignette will focus on the 5 domains described, but not in exactly the same manner as this vignette. Scores from all the vignettes provide a composite score for the examination. It is extremely important that candidates keep the content of the examination confidential and remember not to discuss the vignettes with others. Further advice about test-taking techniques is given in the Part 2 certification examination information for candidates on the ABPMR website.